it's this view that the individual somehow is being deliberately difficult, and actually it's much more about a systems design in terms of how do you design a system that encourages people to come and engage with that system. Welcome to the Research for Good podcast. My name's Professor David Ellis, and this month's going to be slightly different because I'm actually going to be the guest this month, and our producer Emma is going to ask me the questions.
Yeah, David, welcome to the podcast.
Hello.
You often sort of describe yourself as a psychologist or a behavioural scientist rather than a management researcher. So how do you find that kind of overlaps with management?
It's a good question. I mean, it's quite nice really, because there's lots of people in the management school that are kind of the same as me. I mean, I think the school has lots of management-y people, but then it also has this kind of really interesting interdisciplinary cluster of other people. And in a way, I always think that management has sort of had to deal with that interdisciplinarity from day one, because it is made up of, people who did management, but then it's also made up of people who were engineers, or their background is in computer science, or psychology, or sociology. And it's almost like they're not actually in the institution of their original degree or even their PhD, but somehow it just works. For me personally, I find that a more stimulating environment to work in. It probably causes more friction in other ways because you're coming at things from different disciplinary lenses sometimes. But I find that more engaging than being sort of stuck within, a single lens.
You've done a fair amount of work in the sort of healthcare space. What led you into that intersection of technology, healthcare?
Yes,
people?
I mean it is the longest collaboration I've had with like one or two individuals who I met during my PhD. Andrea Williamson, who's still at Glasgow, in particular, and essentially I was doing work looking at patterns of non-attendance in healthcare. That kind of came off the back of very sort of cognitive psychological experiments looking at how people associate emotions with different days of the week, and essentially I found that people miss more medical appointments at the start of the week than the end of the week in secondary care, and that changes depending on what age you are. So if you're in the working population, that incline is larger, whereas if you're retired, the days of the week don't matter so much. So you can imagine how you can then intervene with that and say, well, actually, why don't you move everyone who's over 65's appointments to earlier in the week and all the people, and so we did that in another study and showed that you could improve attendance. But at that time, other colleagues at Glasgow in health were also really interested in non-attendance and people who are not turning up to medical appointments. And I think it was probably like my second PhD supervisor who did a sort of intro and sort of sent an email and said, David, Andrea, you should have a chat. And so we had a chat, and then that's led to a variety, 10 plus years of collaborations, basically trying to both understand what's going on around non-attendance in health settings, particularly people who don't turn up to multiple appointments. So sort of understanding that problem from a variety of different angles, both using a lot of data, but also doing it in a kind of sort of smaller data sense, sort of qualitatively, and then trying to develop interventions, and then trying to see how we can measure if those interventions work to make sure that people are getting the healthcare that they need.
That feeds quite nicely into my next question, which is you've published quite a lot around this idea of missingness in healthcare. So do you talk about what the term means, kind of the factors that influence it, and the approaches you've been taking with researching it?
Yes, I mean, missingness essentially refers to people who, despite repeated offers, will not sort of engage with the healthcare system over repeated attempts maybe to do so. So we're not talking really here about the sort of people who, book a GP appointment, get better, and then just forget to cancel it one off. We're talking about people who repeatedly are not engaging with the healthcare system. And some people might think, well, so what? Maybe that doesn't have maybe it saves the NHS money. Maybe that's not a bad thing. But I mean, one of the first studies we did was to first of all sort of across like a huge sample of the sort of Scottish population, was to understand, well, how often is that happening? And I mean, there's tens of thousands of patients who are missing multiple appointments over a sort of 3-year period, and you can measure this by linking data from medical records and GP surgeries. And that was kind of the first study to sort of really quantify what the problem looks like. I mean, the story would have ended there if it turns out there wasn't multiple people missing multiple appointments. This was based on clinical sort of intelligence, and it was a way of testing that using kind of epidemiological approaches. But probably the thing that came after that was then to say, well, we can link that data to things like education records and death records, and so you can sort of see what's coming in the lead up to this missingness, and also you can see what might be happening afterwards. And again, these are not causal, but they're longitudinal sort of ways of looking at it. And so what you find is sort of, if you look at people who are missing multiple appointments, you find that if you follow them up after 3 years, they're many, many more times likely to have come to harm, in this case early death, than if they had been attending. And you can do you can do a sort of variety of statistical models, sort of control for a variety of things that we know would also affect that. But when you control for all those other factors, what comes out of what's important is this engagement with the healthcare system. I think the number was, particularly people who are suffering from multiple mental health problems, they were 8 times more likely to have died after a 3-year period than the sort of similar patients who were attending appointments. And they were unfortunately passing away from things that you would sort of expect, like suicide or harm or just disappearing almost. So you kind of got this kind of earlier part of the work, if you like, was sort of quantifying this. Is this, what does the problem look like, and what might be the actual outcomes? And of course, those kind of results are the sort of way that you get government and other places to go, whoa, this is life and death. People are dying. And so more recent work's moved on to sort of try and understand the sort of more the why question. So we know there's large groups of people from various parts are not turning up. Bad things might be happening or appear to be linked to those events. The other thing I should say is that if you go back to people's education records from school, lo and behold, you find that people who are excluded, people who've got poor school attendance, not engaging with the education system, also then don't engage with the healthcare system.
So almost people who have learnt not to trust the system early on,
and that's
feel that they've been failed by it, then feel that that's a sort of pattern that might continue.
Yeah, and I think that's sort of what. And I should add that I'm more of a quantitative person. It's other more learned colleagues and more qualitative expertise that's come in to, as you can imagine, trying to identify people who are missing from a system to then ask them questions about why they were missing is actually quite a task in of itself. But as you've just hinted at, when you actually then speak to those people, part of it is around there's elements of trust or judgment, but also it's referred to as sort of candidacy, in that people don't feel they're candidates for healthcare. For whatever reason, it's not for them.
Okay.
But I think interesting, again, the sort of like surface level explanation or kind of layman perspective, and we've heard this in previous governments, this idea of, fining people for not turning up to appointments. It's this view that the individual somehow is being deliberately difficult, and actually it's much more about a systems design in terms of how do you design a system that encourages people to come and engage with that system, or whether that's health or any other kind of, you could apply that to other systems, whether it's social care or whatever else. I think the research team sort of in the current project is again very interdisciplinary. It's drawn from lots of different academic spaces, but there's an agreement always on this idea that if you can design healthcare systems for the people who are the most in need and the most unmet need, then it's kind of designed for everybody. At the moment, a lot of healthcare systems are designed for a specific type of person who will engage and who has access to X, Y, and Z technology, and it will work. But that misses a lot of people who are the most in need. And of course, it's not simple. It requires resources. It requires money. Yeah.
And so in an ideal world, what would you say that might look like? Does it need to take a more holistic approach to target these people to help them access? Pretty
much. And I think, the sort of interventions we've kind of come up with is around this idea of putting missingness within the centre of everything that, say, is done within a practice. That could be a primary care practice or secondary care practice. And it's, part of that is about identifying people who might be more at risk at missingness. But part of that's also just about embedding that in everything else you do to try and see, is it a transport issue? Is it, what can be done? There was earlier work we did where it sort of showed, having more appointments on the day might be helpful for some people, but it might not be helpful for others. And one of the kind of following these kind of sort of interventions, we're now wanting to go forward with the work and sort of test how they actually work in practice. Because so one of the things that the work's sort of done so far is that because of the sort of numbers we're talking about and the impact this might be having on patients, there's lots of GP surgeries in particularly in Scotland, but also in England, they've already started to do things to re-engage patients who are, dropping off of lists. And of course the digital data is technically there. You can build systems that will flag patients who have missed X, Y and Z appointments, what's going on. And so we want to know, one, what's going on out there already, but then we also want to try and test, well, what's different between those places that are doing things and those places that aren't, sort of like maybe a kind of natural experiment. And if we can do that, then we've got even more evidence that actually... Because I think one of the things I've learned about the NHS, I think, is how there's so much... I suppose it's like any kind of massive organisation, there's so many great things going on, but then there's a challenge of capturing that and then sharing that best practice, particularly around sort of just when it comes to managing patients. And I say managing in a kind of not necessarily hardcore management way, but just helping people through that system, which is complicated.
And then I suppose the work you're doing around data and evidence in that is useful for backing up sort of policy justification.
Yeah, and I think that's the thing is that, I think the irony is I've also discovered that a lot of change in policy is, funnily enough, often driven by qualitative work. In terms of like you ask people, so we could get into, without drifting into another topic, but if we think about what drove the decision to ban social media, the government have made that decision based on various consultations or asking people, are you worried about this? That's fine. But the actual population evidence to say this will improve the youth health isn't there quantitatively. So it's kind of made me realise that quantitative evidence is still extremely powerful, but actually a lot of stuff within policy is qualitative. I think I didn't really realise that. If you'd asked me that 10 years ago, I would have thought different.
So I know you've recently been appointed to the DSIT College of Experts. Could you tell us a bit about that?
Yes, there was a call put out, probably at the start of this year. And various government departments already have College of Experts. And essentially it's the idea that you provide sort of ad hoc guidance or advice. It's sort of like consultancy, but free.
And could you explain for people listening who might not be familiar with the acronyms what DSIT currently stands for?
So DSIT currently stands, it still does exist as of today.
Yes.
It's not actually been, by the time this goes out, it may have become something else. Department of Science, Innovation and Technology. And it was created by Rishi Sunak, previous Prime Minister. And it was the idea, there's a lot of things set under DSIT. So the whole of UKRI, that funds a lot of our work, sits under DSIT, for example. But it's this idea that, you bring together innovation and science and good things will happen. It has a very large remit. So there was this call for sort of people to say, do you think you could provide expertise? And it was an enormous, as I've learned since, there was about 1,200 applications and it was a large sift to get to whatever it was, 70 something of us, and we you do the sort of usual things, and essentially put everyone in a room and have a chat. I thought it was interesting that there wasn't as many behavioural scientists. I would say this, right? There wasn't as many behavioural scientists there as I thought there would be, and I think there are plans to have further calls. But of course, now that DSIT is disbanding, we're all probably going to be moved into different... I suspect the plan is that the college will be moved into wherever different parts that we align with.
Yeah.
So it will be interesting. I think a lot of people who are in the college have probably given advice to government on other things before. And so that was a way of, that was probably like, well, let's formalise some of this a bit more, which is nice. But yeah, I think it's an interesting place to sit in.
And is that something that you've done before yourself, giving advice to government?
Yeah, so I think I've probably had lots of... myself and other colleagues here were involved with sort of, government-funded work around things like social media. And, I think most of the work that I'm involved with now has I'm quite, I think I said that earlier, I was quite a practical, applied person. I have done... Theory does interest me as well. But I quite like trying to solve problems or understand what's going on, and so some of that work lends itself to policy at the moment. I think at the moment that's where some of that is. So it's just, I find those conversations just very... I guess personally I'm always a bit concerned that it's quite easy to get very comfortable in academia. Some people might hear that and go, how can you ever... That's nonsense. But I think it is, because I think you get better at what you do and you can keep doing that thing.
Yeah.
And that's great. And we need... people need... That's a good thing. But I'm kind of sort of the person that kind of likes jumping around a bit. And...
Well, I mean, quite a lot of your work has been done in partnership with general practitioners. Do you value that kind of practical insight that they bring to the table?
Yeah, because they tell you you're wrong. I think there's a real risk in that the more senior you get as an academic, people just go, yeah, that's great. Yeah, okay, I'll do that then. Yeah, okay, I'll do that. Now, that's not to say that it doesn't infuriate me when people might... There are times where I might say a thing that is actually the right thing, right? I'm not saying that it's all wrong. But it's very easy to get into the point where you're, like, not challenged. Not because you're a horrible person, but just because people accept that you might know. And I think going into these new environments like policy or having conversations with people, whether that is people who are at the who are general practitioners or healthcare providers, or people in industry, or people who have committed their life to whatever startup to build this new thing. The demands and the questions are different, and the knowledge that you hopefully have as an academic is useful in some way, but it's just about reframing that or thinking even more deeply about and questioning. I think it is useful to question what is it we do as academics.
I was going to say, do you find that working with the people who are actually in practice helps you to focus the impact of your research onto the practical?
Yeah, totally. And I think impact, it is, I think it's difficult, but I think impact, if we talk about non-academic impact, I think it is helpful for it to be built in at the start. I think if you're designing projects with the people who are likely to benefit, whether that is patient public involvement, whether that's industry, whether that's healthcare professionals, it does make life a lot easier. It makes it easier for the impact. It certainly doesn't make it easier as a project. It doesn't make it's more difficult to work with different disciplines and different industries, because you do have those different demands. Again, like everything else, the more you do it, the more straightforward it gets. And you build those relationships where you all bring you can never be the person in the room who knows everything, because you're not coming from it from the same angle they're coming from it, and vice versa. And so you kind of all become quite dependent on each other. And I'm not going to say which colleagues, but there's people that I've worked with for years who are not quantitatively as able as, say, maybe some of the other members of the team are, and they accept that. But that means they're really reliant on them. And I would say the same as I'm not a qualitative researcher by training.
Yeah.
So I am heavily reliant on those people to help me understand. And eventually maybe I'll do a qualitative piece of work on my own one day.
Yeah.
But not today.
What is next in terms of research? What are you sort of looking to in the future?
Well, I've become increasingly interested in, and it's kind of run, it's not a new interest really, but it's always run as an undercurrent around just sort of how we do research, and whether that's sort of looking at the way that we can build better cultures to support researchers, through to, is the current publication system fit for purpose, through to, how do we deal with the amount of papers that are now being published every day by people using AI in a not particularly helpful way. I'm interested in how you can make those things better. This is now referred to as meta-science. And so there's quite a few projects I'm involved with as part of the UK's meta-science unit.
Yeah.
And some of these new projects are going to look at developing better indicators of rigour, for example, automatically from papers. So it's almost like using AI to combat AI in a way. So, yeah, and I've always been interested in sort of how we can make more use of the data. And again, coming back to my issues with a lot of research, is that it's not very open, it's not very transparent in how things have been done, and therefore it's not really building an effective knowledge base. And I think that does link back to the policy, because then when it comes to some of this being useful to make decisions or useful to drive change, it isn't useful because it's not transparent. You've been listening to the Research for Good podcast. To find out more about research in the School of Management, you can visit our website or click the links in the episode description.